This is Simon Searchlight's Behavioral Interventions Q&A. My name is Curtis Weaver, and I'm a Simon Searchlight Research Assistant, and I'll be hosting the session for us this afternoon. So you should be able to see and hear me on your screen. We aren't going to be able to see or hear you, but we're hoping that this session can still be fairly interactive. So we welcome you to ask questions in the chat box below or the Q&A box. So if you're using Zoom, you're going to see a Q&A box specifically, and if you're using Facebook, you'll see a chat. We would let you know that if you're submitting a question on Facebook, others will be able to see that. So we would encourage you to avoid including any personal health information just for the sake of your own privacy. If you're using Zoom, that should be less of a problem. But when we would ask your question, we will remove any information that sort of identifies you. So here with me today is Dr. Cora Taylor. Dr. Taylor is an assistant professor and clinical psychologist at Geisinger Autism and Developmental Medicine Institute in Lewisburg, Pennsylvania, and is a principal investigator for Simon Searchlight. So Dr. Taylor completed her graduate training at the University of Tennessee and a research and clinical postdoctoral fellowship at Vanderbilt University. She has expertise in the diagnostic evaluation of children with a range of developmental concerns. At Geisinger, Dr. Taylor conducts research and leads a variety of current research protocols with a focus on characterizing individuals with rare genetic conditions. Dr. Taylor has experience in engaging families and family-based organizations for rare genetic conditions and research through online participation that is offered internationally to patients and families. So today, Dr. Taylor will be answering questions related to problem behaviors, education, early intervention, diagnosis of autism, sleep, feeding, toileting, and other behavioral interventions for individuals with neurodevelopmental disorders. And those could include things like autism, epilepsy, intellectual disability, and more. So we're going to be answering a combination of questions that were submitted ahead of time. So a big shout out and thank you to those that submitted in advance. And if a question comes to mind while we're sort of answering questions or something comes up, please feel free to also ask that, and we will try to answer as many as we can live today too.
Thanks very much, Curtis. Before we get started with actually answering some of the questions that you submit live or that you submitted in advance, I'd like to start just by telling you a little bit about Simon Searchlight. Simon Searchlight is a research registry trying to advance the genetic science of autism as well as other developmental disorders. In Simon Searchlight, we have participants that have a genetic diagnosis, one of more than 150 genetic conditions on our study list. Families can register online, provide a copy of their genetics lab report, talk to one of our genetic counselors on the phone, and complete some surveys online. We work with leading scientists, patient advocacy organizations, as well as our families and research participants to further the knowledge of genetic conditions and share those advances in research back with you.
Great. So we're going to go ahead and start with the questions, and then just as a reminder, we probably won't be able to get to all of the questions that were asked in advance or asked today, but we will do our very best. And then just as a warning to some medical specific questions that are out of Dr. Taylor's area of expertise are not going to be covered today. So yeah, let's just dive in and we'll start with our first question. So the first question is related to behavior, and that's how can we help kids tolerate wearing clothing?
Yeah, that's a great question. That's a really common thing that we see sometimes, especially in our children with autism, but we will see children with a range of neurodevelopmental conditions having some kinds of sensory sensitivities, and sometimes that sensory sensitivity is related to the way that clothing actually feels on their skin. The approach that we typically will recommend using is something that we call systematic desensitization. And what that means is that we use gradual exposures to clothing to help children tolerate clothing for longer and longer periods of time. I would recommend starting out with clothing that's very, soft and as comfortable as possible, potentially even some clothing that's a little bit more loose, and then working on encouraging the child to wear clothing for a longer and longer amount of time. Building in praise, rewards for longer time wearing certain items of clothing can also be helpful. So you could say, first we need to put on on our shirt, and then we're able to earn a reward. So first we put on our shirt, then we can go outside, or then we can have access to a preferred toy or activity, and work on extending the amount of time that a child is able to wear clothing. I also would recommend like picking battles about what items of clothing the child must wear. And by that, I mean which fabrics they must tolerate. So sometimes we know that children might struggle with tighter fitting clothing, they might struggle with denim. And so thinking about, is it important that your child wears jeans, or is it more important that we're just having them wear some sort of clothing on the bottom half of their body? So we want to work on any clothing, and then we can work with them on different fabrics over time. But I would start out with very simple strategies of increasing the amount of time that they will tolerate something very comfortable, and then we can work up from there.
Awesome. Really great answer. So another question here related to behavior. So this is about repetitive movements. So the question is, do repetitive movements need to be stopped as they're occurring? And is there a point to which, if the parent should intervene, when is that?
Okay. So again, repetitive movements, very common across a range of neurodevelopmental conditions. Even though we think about them associated with autism, many of our children with developmental differences will display repetitive movements of some sort. I would actually avoid calling too much attention to repetitive movement. Sometimes when we call attention to certain behaviors, we actually will have the opposite effect, where we will make that behavior occur more frequently. If the repetitive behavior involves your child injuring themselves, then of course I would absolutely recommend that you intervene right away with that behavior and try to keep them safe. But many of our children will continue to display some repetitive movements over time that are difficult to completely eliminate. If they are distressing in some way, we can always redirect them to another area. So if you're thinking about that as more of a private behavior, a play behavior, then redirect them to their room when they're engaged in repetitive movements. But I would be very cautious about calling too much attention to those repetitive behaviors.
Yeah. So, and then this next question sort of ties into that a little bit, and that's, how should aggressive behavior be managed, so that both to themselves and maybe to peers and others?
Okay. Yeah. So aggression there's a lot of different things that we need to think about when aggression happens. So the first thing we want to think about is, why is the aggression happening, or what do we how can we figure out why this is occurring for this child? If there are severe aggressive behaviors that are occurring very frequently, I would absolutely recommend that you talk to your child's support staff about something called a functional behavior analysis, because aggression can be occurring for a variety of reasons. It could be occurring because there's a denial, so they don't have access to something that they want. They could be frustration related to communication. It's important to remember that all behavior is communication, and especially for our children who are nonverbal or minimally verbal, aggression might be a primary form of communication for them, because they know that it's going to get a reaction or a response. And that's the other important thing to remember, is just like with the repetitive behaviors, if aggression always gets a reaction or a response, a high reaction or response from parents or from support staff or other individuals in the child's care, they might actually be making the aggression worse. Now, we can't ignore aggression entirely, because we want to keep our children safe and we want to keep their peers safe. So I would recommend, what is the minimal amount of intervention that you can do to keep the child safe during those aggressive periods? So for example, if a child is banging their head on the floor, what can I do to block that behavior or make it safe? So by putting a pillow under their head, but not giving any extra attention. So in those situations, I would refrain from trying to talk to the child, refrain from trying to calm the child down very actively, but just keeping them safe in that moment. And as soon as they're recovered, then giving all of that attention. And then in the process of figuring out why this happened, we want to also build strategies or other ways that that child can communicate with us that does not involve aggression. Sometimes that's by increasing their communication through non-language means. So alternative or augmentative communication devices can be helpful for children who are aggressive and nonverbal or minimally verbal. In terms of aggression towards others, similarly, we want to try to end the behavior by protecting ourselves and others, but not giving it any too much attention for actually engaging in that behavior, and then teaching other strategies to have access to preferred items or skills without that do not involve aggression.
Yeah, so that's a really great response. And somebody had sort of a similar question. I think you sort of answered it in what you were just explaining just now, but I'll just repeat and you can reiterate. So children who exhibit aggressive or repetitive behaviors are often punished at school by being denied a reward, for example. So is that an appropriate response? What would be the appropriate response if you would have to sort of try to stop one of these behaviors?
So for repetitive behaviors or aggressive, I mean, definitely we don't want to be calling too much attention to it. We definitely do not want to be punishing. That is absolutely not an appropriate response. Denying a reward, ultimately we might want to just redirect in the case of aggression or in repetitive behaviors, like I mentioned earlier. Those are more of a symptom rather than the child doing something wrong. So I'd be very hesitant to say that they're going to be denied a reward for, say, hand flapping, which we know is a symptom. In terms of aggression, there are lots of different strategies that we could potentially use. And in some cases, being allowed access to a reward could come from the child, even if they had an aggressive incident, the child engaging in a more appropriate way to ask for that. Because we also want our children to be successful. If children are unilaterally denied rewards, then it's very difficult to teach them what the appropriate behavior is. So we kind of have to get the ball in our court a little bit, and it does depend on exactly what's going on and what the precise situation is. But working with your team members to put in what we call a positive behavior support plan. So we're intervening before the behavior even happens rather than being reactive to the behavior that we don't want to see.
So then switching gears a little bit, so we were talking about different behaviors. So now we're going to talk about toileting because there were a lot of questions that had come in about that. So I'll go ahead. So how can you encourage kids with neurodevelopmental disorders to use the toilet, especially if they have difficulty going due to constipation? And then also just general how to help potty train our children with special needs.
Okay. I'll start by addressing the constipation question first. That's very common that children with uncontrolled constipation are going to have some toileting resistance or might be able to gain control for urine, but then really struggle with bowel movements. So it is critical in those children that we try to manage the constipation as best we can. It's important to work with pediatric gastroenterologists sometimes to get those things out of control. Sometimes there might be cleanouts, there might be imaging that's indicated for those children. And also getting them on a consistent medication regimen can be helpful for many kids. Often what we see sometimes with kids who are having a lot of trouble is that they'll go on a medication such as Miralax and they'll start, their constipation will be a little bit more managed, and so we'll try to wean them off, and then they'll have a setback. So often the medications that your pediatrician or your GI expert is giving you do need to be taken every day, regardless of kind of how the child has been doing. So it's having a really good partnership with your pediatrician is the first step there. And in terms of toileting in general, it's definitely a process, and expect that it's going to take a little bit longer and that it's going to take a lot of repetition in order to have the child fully toilet trained. And it depends upon, I would think about, where is your child right now? So sometimes we have kids who won't even go into the bathroom or who are very afraid of toilets in general. And where I would recommend they start is a little bit different than where I would recommend a child who will already sit on the potty would start. So for a child who's really at the very beginning, all we want to work on is tolerating sitting on the potty. And that can involve special toys, activities, iPads for actually just having a successful sit, and then working on increasing the time that they're able to sit on the potty. Once you have your child able to sit on the potty, oftentimes we'll start out with just accidental successes. So initially your child, even if they have, even if they urinate in the potty the first time, they might not necessarily make that connection that this is where I'm supposed to do this every time. So we're going to start out with just getting accidental successes. And if you want to work on this at home over an extended period of time, there is a method called the rapid method of toilet training, where we give children lots and lots of juice to drink and we take them on timed sits every 15 minutes or anytime they have an accident, because we really want to build that connection of every time we urinate, we have to go on the potty. And I'm focusing on urination here because typically that developmentally comes first. And once you have urination, then working on bowel movements is a natural next step. By giving them lots and lots of juice, we're just increasing the chances that they're going to have an accidental success on the potty. And that's the first thing we want, is just the accidental success. Another question that comes up a lot is, should I move my child away from diapers or pull-ups and into big boy or big girl underwear? And that is a common recommendation, because what diapers or pull-ups do is they prevent discomfort from actually being wet. So we can teach children to better make that connection of, I don't want to be wet, as a motivator to try to sit on the potty a little bit more. For children who are really struggling with toilet training, though, that does come with significant consequences, where you could have a child who's urinating very frequently and could take place over the course of working on toilet training for a very extended amount of time. One strategy is to put the underwear on under the diaper, so you're protecting your house and your home, but you're still allowing them to feel that discomfort associated with urination. So to sum up, I would recommend essentially that work on urination first, make sure constipation is under control, and expect that it's going to take a significant amount of time. Once you have urination under control and you want to move towards bowel movement, sometimes things that we'll see is that children will urinate on the potty, but they'll refuse to have a bowel movement on the potty. And then as soon as the parent puts a diaper or pull-up back on them, they will have the bowel movement. One strategy for that, and we conceptualize that as a difficulty with change. So many of our children are very upset or anxious about even small changes, and that change from I'm wearing diapers and I have bowel movement in my diapers to having one on the potty can be a distressing change. So there's a strategy called diaper fading, where you start by just cutting a hole in the diaper so that even though they still feel that pressure of having the diaper on them physically, they still are actually having the bowel movement in the potty, and we can direct their attention to that as well, and then slowly make that hole bigger and bigger and bigger until there's no more diaper left. So you're kind of easing them out of wearing a diaper rather than saying like diapers today, no diapers tomorrow.
Great. And so this other question here was asking about, they were concerned that maybe their child was afraid of the toilet because of how large and intimidating it might be. So for that child, you would probably start by just trying to get them to tolerate sitting on that toilet.
Yeah, example. I would start with tolerating sitting on the potty. And there are, so you can obviously get a smaller potty, or you can get an insert for the bigger potty. So it just makes the toilet bowl just a little bit smaller, if that might help encourage them to actually sit on the bigger potty if you wanted to start there rather than getting a smaller potty chair.
Okay. And then this other question related to toileting was about, what tips do you have for helping a child become potty trained at night?
Okay. Yeah. So that one, that's a good question. So much of the time, it's often very developmental. So it is not atypical for even typically developing children to continue to wet the bed until about age 7, at which point most children will stay dry at night. It's also sort of a is the bladder muscle like strong enough in order to last that long? There are some methods that you can try, but it does potentially, if the child is sleeping entirely through the night, but really they need to get up and urinate at some point during the night, it does involve waking them up. So there are like toilet potty bells that when it's like essentially a wet sensor sensor, and so it would wake the child up when they need to actually get up during the night and use the potty. That's fairly commonly used on typically developing children to actually wake them up and have them use the potty in the middle of the night.
Great. All right, so then we can go ahead and switch themes a little bit here. So that was a lot of really great questions and answers about toileting. So the next sort of topic is language. So how can we help our nonverbal children with communication?
Great question. And really communication feeds into all these things we're talking about, because we have, we want our children to, be able to tell us their wants and needs, which we hope will reduce inappropriate ways to have wants and needs met, like aggression that we talked about earlier. And also we want our children to be able to tell us when they need to use the potty. So communication really is one of the key critical things to help your child with, especially if they don't have the words to let you know what they want and what they need. And I alluded to this earlier, but what we're talking about here is what we call augmentative and alternative communication strategies. And there are a wide range of them. There are what we would call low-tech options. So some of you may have had your child introduced to sign language like more and all done. And that is considered a low-tech strategy. So we're not relying on like an iPad or a dedicated device at all. Some of you may have also had your children using something called a picture exchange communication system, where they might have some pictures of things that they might want or activities that they like, and they can select an icon from their book and deliver it to a caregiver or a teacher, and that lets the teacher know what they want. That's a good way to start. PECS in and of itself has a very specific methodology for how you teach a child to use PECS. So it is a little bit more complicated than, say, a choice board, which sometimes we'll see individuals use. So say on a fridge, it'll just have, a bunch of pictures and the child has to point to or touch which one they want. One nice thing about PECS is that it doesn't require that your child points, which is something that might be difficult for some children who have autism spectrum, where we don't see those skills develop as easily, or children who have fine motor difficulties. PECS is sometimes preferred because when we get to the higher tech options, they have to select icons on a screen and navigate an iPad fairly well. So it does require a certain amount of fine motor development to use some of the higher tech devices. PECS, there are systems of PECS that actually allow children to evolve into putting together short phrases or sentences, like they have an I want card, and then they might add another card to that. PECS can get unwieldy when a child's vocabulary gets really big, because then they have a huge binder, and we want to make sure that that binder is available to them at all times. So it goes to school with them so they can communicate at school, but it should also come home with them so they can communicate at home. So then they're required to carry it around. Once we get to that point, especially with PECS, it's reasonable to entertain a higher tech option. So often these are apps that are available on the iPad. There are also what we call dedicated devices. So it's not on an iPad, but all it is a communication device. Even if your child did end up using an iPad, we do want them to have it be the only thing that they use that iPad for. So we want it, if they have an iPad that they play on, that's fine, but we want to make sure that they have an iPad where it just has their communication app on it, so they know that this is not a play iPad, this is my talk iPad. There are a range of different options. I would recommend finding a speech therapist who can actually do an evaluation with your child. Many of the speech therapists who specialize in these types of apps, and also just augmentative and alternative communication in general, will be able to trial your child on different apps and see which one they seemed to intuit the best, and also kind of just get you started with setting everything up. Sometimes the higher tech devices can be expensive, but we have had good luck working with insurance companies at times to get those iPads and those programs reimbursed, especially if you've been working with a speech therapist who has worked with your child on their device on a range of different programs, has identified and selected the correct program, and has started training and with that communication strategy.
Yeah, I mean, there's a lot about language here. I mean, we could probably do a whole session just on language. So we're going to switch gears again here. The next topic is about feeding. So what is helpful for teaching children how to feed themselves?
Okay. So self-feeding often really gets into fine motor. So if your child struggles with fine motor, I would anticipate potentially that they're going to struggle a little bit with self-feeding. So the first self-feeding, kind of the earliest self-feeding that you'll see children do, of course, is finger feed. So are they able to, that's where a good place to start, are they able to independently pick up a piece of food and bring it to their mouth? And then from there, then we'll see children start to use utensils. So spoons come first, being able to grasp a spoon and bring it to your mouth, and then forks. Forks are a little bit harder to load than spoons. So sometimes you'll see kids who are just learning how to use a fork, they'll load the fork with their finger and then bring it to their mouth, as opposed to actually being able to do the stabbing. So thinking about where your child is on that spectrum, I would want you to identify, and working with your child's occupational therapist here would also be critical, because there are adaptive spoons and forks that are bigger or come with a strap that might be helpful for your child if they have trouble with grip strength as well. So I would start out with loading everything for your child and giving it to them, and then having them bring the bite to their mouth. You're taking out a little bit of the difficulty and kind of giving them like an intermediate step that they can work on while they're working on their strength and their other skills, and then getting to the point where they're able to scoop or stab and feed themselves.
So then another feeding related question. So some kids are really selective on what they eat. So how can families help increase the variety in their children's diet?
Great. I would absolutely recommend a book in this case to start with, Broccoli Boot Camp. It's a good place to start and has a lot of different behavioral strategies that you can use to increase your child's diet. In some cases, you might want to also consult a feeding specialist, depending on how restricted your child's diet is, especially if they will not take a multivitamin, and if they will or they will not take any kind of supplement. So my first question is, how severe is the feeding issue? And do you need a specialty consult, or at least a nutrition consult, to make sure your child is staying healthy? And then what behavioral strategies can we use? So there are, and again, this is very personalized to kind of where your child is, like on the picky spectrum. Keeping in mind too that it takes a number of trials. It takes quite a few times for a child to be introduced to a food to actually start accepting that food. So I don't give up on presenting a certain food just because they've rejected it one time. I would keep trying the same foods. And also, for starters, will they even tolerate having this food on their plate? Will they tolerate having it on the table? And starting kind of where your child is and taking baby steps from there, but also using preferred foods as a reward for taking a bite of non-preferred food, almost like a first then kind of strategy to help introduce them to more foods, so they have enough introduction so that they know that they like a food.
Okay, great. So then we did have a question come in, a clarifying question about language. So somebody wanted to know, what is PECS? Was that an acronym? Did that stand for something?
Yeah, that's Picture Exchange Communication System is PECS. I apologize for that.
Great. All right. So then we can switch gears again here. So we have some questions about behavior issues and neurodevelopmental issues. So how can you tell the difference between what's a behavioral issue and what's a neurodevelopmental issue?
That's a good question. So they are, I would say in some ways they are inextricably linked, because neurodevelopmental issues might lead to some of the behavioral issues, but so just like we've talked about a little bit, where some of the communication issues, so the language delay, which is a neurodevelopmental issue, might lead to communication problems, which sometimes can lead to maladaptive behaviors. So behaviors like aggression or hitting, those, like they're all, I think it's, we have to think about it kind of as a feedback loop, where we can't completely separate one from the other, when we need to think about the child in a really holistic way and try to understand how neurodevelopmental issues might be impacting their behavior. And keeping in mind that behavior is communication of some sort. So for we've talked a lot about kind of nonverbal or minimally verbal children, but for those kids, their behavior is trying to tell us something. For children who are perhaps more verbal or more advanced in their skills, but do have some learning concerns, it doesn't mean that their behaviors and their learning are not linked. So for example, for an older child, we might have a child who has a significant reading disability, but if their IEP is not giving them material that's at the appropriate level, we might see that they're acting out in class. So that's not just a behavior issue, that's also a neurodevelopmental issue, because if we're not giving them classwork that they can succeed at, sometimes we'll see increased acting out. So I would try actually to think about this issue as a whole child approach and try to identify, are there any neurodevelopmental issues that are causing or impacting behavior?
Okay, great. So then what should early intervention look like for individuals with neurodevelopmental disorders? And then second part to that is, how would that look different if the individual has a known genetic condition?
Great question. So early intervention should always involve an evaluation that is either directly with the child or a parent interview about current skills and concerns, or a combination of those two things. That will help the early interventionist identify where the child has needs. Often we see a lot of our children having needs across the board, and so needing speech therapy for speech and language and communication skills, needing occupational therapy for fine motor development, physical therapy for gross motor development, and then sometimes you'll see early intervention programs also include some type of a preschool placement if they're a little bit older, or have like a developmental teacher who comes in and does different tasks with the child. Some children might also need some type of behavioral specialist working with them in early intervention. So I think thinking about what your child's unique needs are, not everybody is going to need all of those things, but many individuals might need at least one session per week of those. So we often recommend that if the early intervention identifies that maybe your child isn't eligible to receive occupational therapy, but you look at the testing and you see maybe they were a little bit below average, but not so delayed that early intervention gave them occupational therapy, you might consider seeking out outpatient therapy for them so that they can access that, since outpatient therapy doesn't have necessarily the same rules or regulations about when a child does or does not receive a service. For the second part of that question with genetic conditions, sometimes genetic conditions can help inform what we know about a child's likely path of development, but sometimes a genetic condition gives us much less information. There isn't any clear link right now between having a genetic condition and specifically which interventions you should receive in most cases.
So then, for speaking of sort of the genetic disorders, so how should you approach being newly diagnosed with a genetic disorder? And then the second part of that would be, how should families go about educating others about their child's condition, including medical professionals?
That's great. So the first thing is identifying your genetic counselor. So sometimes the individual that ordered the test for you might not be the same person who gives the results back to you. So the number one is identifying a genetic counselor who can help explain the genetic result to you and what we do, and sometimes in some cases what we do not know about a specific genetic condition to date. Depending on the genetic condition that you have, there is often a range of amount of information that we know. Some genetic conditions we know quite a bit about, and some we know much less. It's also important to note that some genetic conditions have a really wide range of outcomes and neurodevelopmental paths. So sometimes the genetic condition might not tell us very specific information, but might just tell us a risk profile of what we might see in a child who is diagnosed with a specific genetic condition. Once you've had a good session with a genetic counselor and had a lot of time to ask those questions about, again, what this means and potentially what it doesn't mean, the next step would really to be seeking out registry-based resources. So often there are often family groups who have registries, depending on which genetic condition that you have. Again, your genetic counselor should be able to point you to those family registry groups. They are often a hub of information. That you can potentially give to your doctor or give to your child's other professionals.
So then another question here. So what is a good age to explain to a child about their developmental differences from other children? So, maybe we can even include genetic differences if there is somebody has a diagnosed genetic change. So we can add that on as well. And then any tips on how to go about this for kids who may start to become aware that they are different in some way?
That's a really great question. So I would emphasize that it shouldn't necessarily be your child's chronological age, but think about your child's developmental age. And that a lot of that is going to have to do with sort of where they are cognitively, or where they are in their development, or potentially the presence or severity of autism spectrum symptoms. So again, this is going to be a really individualized approach. Again, yes, if some children begin to notice or begin to comment that they think they're different, that is often a good sign that it's a good time to have the conversation and start telling them a little bit more about autism spectrum disorders or other developmental or learning differences. Children might realize that that things take longer for them to get through in class, that other children are finished with their work before they are. So those are just a few ways that children might start to realize that they're a little bit different. And I think it's okay, depending, to explain to them at a very appropriate level that perhaps they are different. There are some books for a various range of different conditions to try to explain about autism in particular being a difference, and how to explain that not only to the child themselves, but also to their siblings or peers.
Great. So the next big topic that we have a ton of questions about is sleep. So the first question I think is probably the most basic one, and that's what can be helpful to get children to actually fall asleep?
Okay, great question. So first, we always want to start with our behavioral strategies before we go necessarily down a medication route. But just to keep in the back of your mind, there are a couple different medication options, one of which is fairly commonly used and is available over the counter, called melatonin. There are some prescription options that some pediatricians might prescribe. So if you're kind of at that point where you feel like you need to really get your child to fall asleep because they're not sleeping at all, or they're sleeping very little, which has many downstream effects on behavior and also just the family in general, consider talking to your pediatrician. So a few different things to start out with trying is, of course, having a really good bedtime routine that is very calming and does not involve screens to the extent that you can prevent that. We also want children to try to fall asleep in their own room, in their own bed, to the extent possible. As soon as we start introducing other variables into that, it gets more and more difficult for children to fall asleep. So often parents will lay down with their child to get them to fall asleep, and that can be very effective, but then it can be really difficult to withdraw that support for the child, although there are ways of going about it similar to other strategies I've talked about, where we just slowly fade the parent out of the room in a very gradual way, so the child gets more and more used to falling asleep on their own. But you could potentially try some medication options to sort of put the ball in your court to even start some of these strategies.
So then, related to individuals that have genetic changes, so do we know if there's certain genetic changes that can cause sleep disorders, or do we know why that is?
Yes, there are certain genetic changes that can impact sleep. That's very different from genetic change to genetic change. There are definitely clinical trials underway for certain genetic changes as it relates to sleep, including like prescription-based melatonin that has extended release. As opposed to just the one dose, which helps children fall asleep but not stay asleep, which is a difficult thing with using melatonin. But yes, some genetic conditions can absolutely impact sleep, and that would be a great thing to talk to your genetic counselor about.
So then one other sleep question. So they asked if there was a way to reset their child's bedtime. So their child is having issues where they would go to bed early and then they would just wake up really early. But when they would try to sort of extend the bedtime to go to sleep later, they would end up waking up even earlier. So they weren't able to sort of have a solid sleep schedule that was going to work for the whole family. So what kind of advice would you give for them?
I would advise doing a gradual shift. So I think sometimes the idea is, if a child goes to bed really early and they are waking up, maybe in the middle of the night. So let's say they're going to bed at 4 and they're waking up at midnight. What we want to do is start to shift. So what could potentially backfire is getting the child too tired and trying to get them to stay up late, hoping that you're going to move that earlier bedtime, like you move that wake up time earlier. But actually what you should try doing is a gradual shift of the whole schedule. So if right now, say they're going to bed at 4, I would say, let's try 4:15. Now it's going to take some time to do the shift, or you might try 4:30. We just don't want them to be overtired, because by getting our child overtired, we might further disrupt the sleep. So trying to just gradually shift them to a later bedtime and a later wake up time, rather than trying to push them too hard to go too late too fast.
So then changing themes again here. So one of the questions that came in was, what is the proper way to go about testing for autism?
Great question. So testing for autism is a lengthy process, so it should involve a familiar caregiver. It's an important part of the autism diagnostic process is to have a high quality developmental interview. If your child is a little bit older, we definitely want the caregiver who knew that child around about their 3rd, 4th birthday to be involved, and potentially, ideally, somebody who's known the child for their entire life. The reason for that is it's important to establish that symptoms of autism were present in the early developmental period. So we do need somebody who knew the child when they were very young in order to make a really clinically confident diagnosis of autism. After a developmental interview, there generally should be some additional testing that looks at where they are developmentally right now. If they're older, that might include a formal cognitive or IQ test, but for younger kids, it might include more like play-based assessment, where we're just looking at where their developmental skills are in both speech language and early problem-solving type skills. I would expect that parents would fill out a number of questionnaires about their child's adaptive or day-to-day functioning, things like eating, fine motor skills, their play skills. And then often there's also either a formal or informal behavioral observation that can take the form of a very structured approach, where we have children go through very specific tasks and see kind of what their social responses, where their play skills are, to see if they have any restricted interests or repetitive behaviors. And those would be the key components. So a developmental interview, and then some direct interaction with the child that should include developmental or cognitive testing.
So then what kind of testing should be done and when to determine if there's any cognitive deficits in a child?
Yeah, so I think when children are young, our developmental testing are not the best predictors of outcomes. So if you have your child to see early intervention or a psychologist or a developmental pediatrician, they might do some testing when they're very young. And right at that point in time, when children are under age 5 in particular, that doesn't necessarily tell us all that much about where they're going, especially if that provider has only seen that child one time. So if they do one testing and that child is very young, all they really have is like one snapshot in time of where that child is right now. Once children get to be older than about age 5, so in the window of about 5 to 7, and generally IQ is pretty stable at 7 and older. So if you get a IQ test around age 7, that is likely to be maintain and be stable over time. And that's something that the school can potentially help with. If you wanted your child to have a cognitive assessment or an updated IQ at any point in time, you can ask that the school do that. And potentially, if they're not If they're not doing it as part of a reevaluation, if you put that request in writing, then they have to respond.
So then somebody also had a question about how to manage what they're calling testing limbo, where their child might have features of autism, but not actually have an autism diagnosis. They don't have an intellectual disability or ADHD, but they have trouble managing in a busy classroom. So what would kind of tips would you give for that family?
That's a really good question, and that's a situation that many of our families see themselves in. And it's because to some extent that some of these diagnoses like autism and intellectual disability, the boundaries about what constitutes clinical autism versus autistic features is kind of artificial. So we have a clinical consensus about what we think makes autism spectrum disorder, but then we also will have other kids who maybe don't meet that strict criteria, but have features of autism. And the same is true for intellectual disability, right? We conceptualize intellectual disability as being an IQ and adaptive day-to-day living scores as being a score of 70 or older, but a score of 75 is not within the typical range. So we definitely have people who absolutely describe what you're talking about, where you fall in this testing limbo. But the biggest question for me would be first is how old is your child? When children are very young, I would encourage you to stick it out a little bit, because sometimes things become clearer as children get older about what is really going on here, especially if you're working with somebody who's known your child over time. So that could potentially be a school psychologist or developmental pediatrician or another provider that you've been working with who's really seen this trajectory of your child. So if your child is a little bit older, and maybe doesn't have a diagnosis and maybe potentially doesn't qualify for an IEP or an individualized education plan. So in order to qualify for an individualized education plan, your child has to be struggling in school and also have one of these diagnoses, but asking the school in writing to actually test the child to see if another placement might be available. If your child maybe does have some diagnosis but is doing better in school, they might qualify for something called a 504 plan, which allows children to access some extra supports without actually going into a different classroom, like a learning support classroom. So I hope that answers your question. I know that's a very frustrating position to be in, but I think also you could potentially seek out neuropsychological testing, which goes a little bit more in depth as opposed to just doing an IQ test to look for, just to try to better understand where your child is struggling.
So, we've talked about autism and we've talked about different genetic changes. So this question sort of combines both of those themes. So would you expect individuals with a genetic diagnosis and autism to have different behaviors than kids who have an autism diagnosis, but not a genetic diagnosis?
No, not necessarily. So autism is a behavioral diagnosis, meaning that we diagnose it based on the behaviors that we're seeing. A genetic diagnosis is what we call etiology. So it tells us why it's happening. And they're not necessarily linked in any kind of one-to-one way. So a child with autism, if there were two children with autism, one with and one without a genetic condition, we wouldn't necessarily be able to identify which child did have a genetic condition and which child didn't have a genetic condition. That said, we do know that sometimes the genetic conditions that we know more about, we might understand a little bit more about the behaviors in that genetic condition, but I would think of those more about being about the genetic condition itself rather than the autism spectrum.
So then bouncing back to some of these behavior questions. So somebody wanted to know, or they said, changes in routine often cause anxiety in our children. So they said that they can use visual aids to help prepare their child for known changes that are upcoming. But how can we prepare our children to handle the frustration and anxiety of something that's unanticipated in their routine, such as missing the bus, for example?
Wonderful question. So I love that you're using the strategies already. So you're using visual schedules to help your child be successful. And actually, in order to help children tolerate change related to schedules, often getting that visual schedule in place is your biggest ally. And also social stories, if you haven't implemented those with your child for potentially more significant or large upcoming changes to prepare them for, such as going on a special trip, or if school's going to be out, or so they know when these major changes are going to happen. I would start by working with small changes that you are deliberately implementing. So often one thing that kind of backfires is that when things change unexpectedly, they also change unexpectedly for us. And so in that moment, it can be hard to manage because we're trying to handle the change and our child is trying to handle the change. And, so for example, if you miss the bus, you're now trying to get your child into the car and you can't help coach your child through that moment. So I would recommend introducing a change deliberately into the schedule where you are going to be able to manage it. So if you have, say, a weekend schedule and you lay that out, if you are using a visual schedule that has like little cards, there is one, I think, on Boardmaker, if you're working with a speech therapist who uses that program that has nice visuals on it. But introducing something called an oops card into the schedule and showing them that oops card when something doesn't go their way, helping them calm in the moment, putting the oops card in the schedule, and then resuming the schedule. And so essentially what we're teaching them is that things might change, but we're going to get right back on track. And so if we only wait when those things happen, when we're also not expecting it, again, we don't always have the energy and the time to really focus ourselves through that, much less manage. So I would actually deliberately introduce minor changes into the routine, start working on those.
So we had another question come in about language. So for children growing up in a bilingual or trilingual environment, is there any evidence for kids with different abilities that this is not recommended? So for example, is it going to slow the language or the language learning, or is it possible that it could be beneficial to have multiple languages being learned by a child when they're growing up?
So, of course, when children are very little, especially very young children, often we don't know if there's going to be any learning differences. And the first thing that we often notice as parents is that their language is not developing. What we know about children who grow up in bilingual households in particular is that in general, there should be no impact on their language skills. Now, if you simply count the number of words that say they might know in English, but don't factor in the Spanish words, if the other, assuming the other language might be Spanish, you'll see that if you just look at the English words, it might appear that they have a language delay. They are not saying as many words in English as other kids, but if you combine the words, so how many words they know in English and in Spanish together, then their language development is actually more on track. I would always recommend for families that you speak to your child in the language that you feel most comfortable with. Certainly growing up in a bilingual or trilingual household did not cause the delay. The delay came from somewhere else. Now, some children are what we call sequential learners, so they don't learn both languages at the same time. So they might learn one language first and then might develop the other language afterwards. So I don't necessarily recommend to just stop using a language, especially if it's not your preferred language. If you prefer to speak to your child in a language other than English, I would recommend you speak to your child in that language.
So then still on this language topic, so how to select the school path for a child with major speech delay? So is it helpful to postpone the start of school for a year and maybe redo preschool to help with the speech? Also, parents considering a regular class with inclusion or a separate class with fewer children that might also have some other disorders, what would be the recommendation?
Good, great questions. So I'm actually going to start with the second question because I think it's a little bit more straightforward. So I think it depends upon where your child's language is. And you might, I always call this like being a big fish in a little pond. Now, I didn't make up that term, but what you don't want is for your child to be the highest language level in a class. So if your child is fairly verbal and they might be in a specialized classroom that has other children with disabilities, but all those children are either minimally verbal or nonverbal, I would actually err on the side of putting your child in the classroom that has other peer models who are saying more than your child. So that, because kids really do learn best from other kids, and kids will learn language from hearing other kids talk. And so if your child is the best talker in the room, they get less of that exposure to typical language. So I would push them into more of the inclusion rather than the specialized placement. And of course, working with your school system, because all kids are very different, and that's only factoring in language. There are lots of other things potentially at play, like maturity and behaviors and student teacher ratio. So it's hard to answer without knowing the specific program, but with just language, I would want your child to have more peer models than less peer models, depending on where they are. In terms of holding kids back, that also is a difficult question to answer without doing an evaluation of the specific child. But in some cases, holding children back will might just lower the difference between them and their peers. And sometimes children do do better on being holding back, and sometimes that helpfulness maintains over time. But it's very individual, and so that's a little bit harder for me to answer specifically. But I would work with the school psychologist who might be doing kindergarten testing for your child to try to make that decision about which way to go.
So then switching topics again a little bit, we talked about feeding earlier. So what would you recommend for kids who are having a hard time actually focusing on the mealtime activities, such as using the cutlery to eat but not looking at their plate?
Yeah, good question. So it depends on, again, this one depends a little bit on the age of the child, but sometimes children do really well with just giving them a little bit more structure. So if they still might be able to like sit with a tray in front of them so that that everything is kind of laid out, rather than like kids who might get kind of fidgety in their chairs and just not attending to it. I also would maybe work on this a little bit more at snack time to try to build the skill, because dinner time, it requires a lot more attention and focus, and it might not be within their range of capability at that point in time to maintain focus for that long. But if you have a snack time where you're just asking for them to take like 2 or 3 bites, that might be a reasonable goal, and then increase the amount of time just by like 1 bite at a time. How long are you able to attend to actually eating the food?
All right, so and then just looking at time, we probably have time for maybe 1 or 2 more questions. So some of the other ones that were coming in. So how common is it for children with neurodevelopmental disorders to have tantrums, and what can be helpful for eliminating those? So that actually might take us to time depending on how much you have.
Yeah, I would say it's very common. Like we've talked about kind of in little threads here along the way, especially in kids with, communication difficulties. We'll see, and in children who just have speech language delays, but have no other apparent delays, we'll even see sometimes increases in tantrums in those kids. So really, any child with a neurodevelopmental condition, we might see more tantrums or more severe tantrums compared to typically developing kids.
All right, and then I think we have time for this one last question. So what resources are available for adults with neurodevelopmental disorders in terms of life skills, financial management, job coaching?
Good question. So when your child reaches age 14, they should start accessing transition services through their school system. And really all that means is we're planning for what things are going to look like when they graduate high school. Some children with neurodevelopmental conditions will graduate at age 18 and potentially go on to technical schools, 2-year, 4-year college and university, depending on the severity of their delays. Other children with more severe delays are eligible to stay in public school until the year that they turn 22. So that gives a little bit more time for things like vocational training and planning for these other resources. I would recommend looking into estate planning for individuals with or parents for a child with neurodevelopmental disabilities. There are some federal federal ways where you can save money in a similar way that you might save for your child's college to save for your child who has a disability. That's very individualized based on what state you live in. So talking to your county office or state mental health and intellectual disability resource office might let you know what might be available to you. When children turn 18, they also, if they depending on their disability diagnosis, they might be eligible for Social Security income. And then parents can also seek guardianship of their child. That's more common in children who have very significant disabilities, and parents need to maintain like their medical and financial decision making.
Great. Thank you so much for answering all these questions today. So as we conclude here, sorry for all the dinging. I'm not sure if anybody can hear my notifications going off. Apologies for that. But we'd like to give a huge thank you to everybody who attended today and everyone who asked questions either during or ahead of time. These were all really great questions. So if you want to learn more about Simon Searchlight, our registry, and how you can get involved, please visit our website. Our website is simonsearchlight.org, and it's SIMONS and then SEARCHLIGHT.org. Sometimes that second S gets a little confusing. You can always reach out to us by email. Our email is coordinator@simonsearchlight.org. So once again, thank you guys so much. This has been great.
Thanks, everybody.